Cool. There we go. So, as I said, it's the 9th seminar, and today we've got Jim Lewsey from the University of Glasgow, who will talk to us about all his work around the evaluation of the impact of minimum unit pricing in Scotland. So I will, we've just tested it. He can show us his slides. So Jim, the floor is yours.
Thank you very much, Frank. Thanks very much for the invite to speak to you all today. Thanks for everyone for coming. Okay, I hope everyone can see my slide deck now. So yes, as Frank said, I'm going to speak to you today about a number of studies that I've personally been involved in, but also other studies that I haven't been involved in, which all are evaluating different outcomes of the minimum unit price for alcohol intervention in Scotland. And along the way, I want to try and talk about some sort of methodological challenges and also thinking forward about how are we going to go about evaluating the new MUP in Scotland, which is due to start this September. So I'm sure everyone is pretty familiar with MUP, but I'm just going to give a short introduction to it. And then go on to the evaluation strategy that was put in place. This is a natural experiment network. So again, I probably won't dwell too much on the natural experiment approach. Before then going on to sort of the suite of studies to give an overview of the quantitative evidence. I then want to sort of highlight the fact that there seems to be a bit of a difference in terms of the impact MUP has had in terms of chronic versus acute harm outcomes. And then further go on to talk about some of the sort of limitations of a quantitative natural experiment approach, specifically when you have quantitative aggregate level data. And then, as I said, I can finish off by looking ahead to 65p MUP evaluation. Now, Frank, I don't know how you normally organize questions, but if there's a burning question, I don't mind being interrupted. Otherwise, maybe we can collect the questions in the chat and we can have a discussion afterwards. So Scotland introduced minimum unit price for alcohol on the 1st of May 2018. And that in itself was quite an achievement. It has a lot of barriers to it. And there were challenges in the court from the alcohol industry. But it kicked off on that date. Importantly, it had a sunset clause, and that is that it would expire on the 31st of April this year, unless the Scottish government voted for it to continue. And it transpired just recently. The MSPs voted for MUP to continue, and what's more, they're going to increase the minimum unit price from 50p to 65p, and that will be from the end of September this year. Now, we could maybe argue about whether that's actually an increase or if that's kind of inflation adjustment. But either way, I think it's a positive step. And the bottom graphic, which came from the BBC Scotland website, just gives you a bit of an illustration of some of the change in prices for 3 types of alcohol there. So in moving towards the evaluation, the Scottish Government tasked Public Health Scotland, PHS, to lead an independent evaluation of MUP. And in particular, it was a group within PHS called Monitoring and Evaluating Scotland's Alcohol Strategy Programme, MESAS, that funded a suite of studies and also sort of gave an overall management and communication structure to the evaluation. And MESAS led this coordination, but also it brought under its umbrella those studies that were funded separately, which were typically led by academic institutions. So kind of my role in all of this was myself and a colleague, Danny Mackay, also here at Glasgow. We had, or we still do, have a kind of a service level agreement with PHS to provide methodological and statistical support to their range of evaluation studies, not just alcohol policy. And we were involved in a kind of a pre-runner to MUP, which was an Alcohol Act, it was called, and this was primarily stopping quantity discounting. So sort of the get 3 for the price of 2 type deals, and that seemed to be moderately effective in terms of impact on sales, and it was also all part of the evidence leading up to the MUP intervention. And in June last year, PHS published kind of a final report, which was a synthesis of all the evidence to date. And I think the criteria for their entry into their synthesis was that it had either been published and peer reviewed, and I also think they admitted papers on like a preprint server like medRxiv. So when MESAS was setting out their strategy, this was the sort of the theory of change they were working with. So starting over on the left here, MUP was implemented. There was a range of studies that testing compliance by looking at the prices of alcohol sold in a range of supermarkets and smaller retailers. If compliance was good, then that would mean there would be a change in the price distribution of alcohol, with no alcohol sold less than 50 pence per unit. This was then hypothesized to lead to reduced purchasing of alcohol and leading to reduced population level consumption. And also, it's noted here, it would lead to safer patterns of drinking, and perhaps we can return to that point. And then following on from that, that should lead to reduced health and social harms. Now, there are other parts to this theory of change, as you can see. So MESAS were also concerned and tasked with looking at the economic impact on the alcohol industry, thinking about the displacement of spending in terms of were consumers not spending money for other goods to maintain alcohol consumption, substitution effects, and also impact on demand for services as a result of this change. Okay, so as I say, I'm not going to dwell on this because I'm sure everyone is cognizant of natural experiment design. But I wanted to bring this up because I think one issue that has been highlighted to me through these studies is two things. One, the importance of having a control group. But secondly, something that's maybe a bit overlooked is how do you determine whether a control group is suitable for providing you with a counterfactual. And the final bullet point as well, I think, is something which is important in that often we're doing studies where we are measuring data at a kind of ecological or aggregate level, and that sometimes leads us, after we've reached our conclusions, with still some obviously unanswered questions, which I would like to return to. Okay, so after setting the scene there, let's move to kind of an overview of the quantitative evidence to date. So this was a study that I was involved in, and this was using market research data from Nielsen, which is like the market kind of the gold standard that the alcohol industry themselves use for measuring alcohol sales. And what we have in this graph is the solid black line is the alcohol sales in Scotland from 2013 to 2019, and the dashed grey line is England and Wales, and then the dashed vertical line is when MUP was implemented. So obviously you can see the strong seasonal patterns in alcohol consumption, with these spikes corresponding to the end of the year, and you can also see that the consumption being higher per capita in Scotland and England and Wales, and it's a bit hard to see in the graph, but there was a narrowing between these two lines, which we found in the first year after MUP implementation, and I think it was in a range of about a 4% reduction in alcohol sales. So here, as you can see, we used England and Wales as our comparator, but we also did a sort of a range of sensitivity analysis by using, for example, the north of England and the northeast and northwest of England separately as our comparator, and the findings were comparable. So this work was published in Addiction. And we've just recently had a follow-up study published, which is using the same data source, and but now with 3 years follow-up of data. So this is a bit of a different way of presenting the data, but essentially the top panel is the data itself. The middle panel is sort of like the seasonal pattern, and then the third panel is kind of like a I suppose, like a residual, sort of the underlying trend after we've stripped out seasonal patterning. And again, as I hope you can see from the graph, but also from our modeling, showed actually that 3-4% reduction in alcohol consumption was still observed at 3 years follow-up. So, so that was good. So thinking back to the theory of change, then obviously this was a key thing that we needed to observe to have happened in this natural experiment, that the MUP led to a reduction in alcohol consumption. And then in a study which was led by Grant Wiper from Public Health Scotland, and myself and Danny were co-authors. This was probably the key bit of evidence that the Scottish government used to determine, to vote on whether MUP was going to go forward. And so here we are looking at a time series of wholly attributable deaths, wholly attributable to alcohol. Again, the blue line is Scotland, the red line is England. And as you can hopefully see, there's a sort of a slight upward trend prior to MUP in both countries. And then after MUP has come in, there has been a drop in the deaths in Scotland relative to England. And showing a few of our modeled results here. So you can see that the reduction was in the range of 13% for deaths, and around 4% for all hospitalizations. However, you can see some difference for when you break down the deaths and hospitalization by causes. So you can see, focusing on the deaths, first of all, that deaths from chronic causes was around 15% reduction. And the point estimate for deaths from acute causes was actually an increase of around 7%. But you can see a high degree of uncertainty and a large p-value for that. And similarly, when you break down the hospitalizations, you can see a reduction of around 7% for chronic causes, and a 10% increase for hospitalizations for acute causes, with again a range of uncertainty, which is crossing the null hypothesis. And one thing to say about this is, of all the deaths and all the hospitalizations, the chronic causes account for about 95%. But again, I'd like, perhaps we can return to this potential differential effect, whether we're talking about acute or chronic later. And then, importantly, when we looked at this within subgroups, it was apparent that there was differential effect by socioeconomic deprivation. So in the bottom of this table, you can see much larger effects for those people who are residing in more socioeconomically deprived areas of Scotland. So again, this was an intended impact of the intervention, was not only improved outcomes, but also a narrowing in socioeconomic inequalities. So moving on, so we looked at sales and we've looked at hospitalizations and deaths. Now I want to look at a couple of studies which look specifically at subgroups of the population and those people who are drinking at harmful levels and those with alcohol dependence. So this was a study led by John Holmes in Sheffield, and this was one of the studies which was funded by Public Health Scotland. And it relies on an online survey data from AlcoVision. It is a controlled interrupted time series design. I've just plucked out a couple of sentences from the final report where you can see the link at the bottom. And you can see that in this study, it said for those who are drinking at harmful levels or those with alcohol dependence, there was no clear evidence that MUP led to a reduction in alcohol consumption. And further, there was no clear evidence that MUP led to a change in the severity of alcohol dependence symptoms. Similar findings were found in this study, which I led with my colleague Francesco Manca here at Glasgow. And here we used prescribing data in Scotland. So there's a system called PIS in Scotland, which has national coverage. And we looked at patterns, a time series of prescriptions for medications for alcohol dependence before and after MUP. Here we didn't have a control group. Rather we had a control outcome where the red line here is the red lines here are for prescriptions for methadone. And on the top two panels are time series of total prescriptions, and the bottom two panels are for new patients for the medications. And either way, as you can probably see from the graph, but what was also confirmed in our models, we found no association between MUP and a change in prescribing for alcohol dependence. Now, certainly for this study, one of the limitations is it's particularly people with severe alcohol dependence who would get prescriptions. So it is a subgroup within a subgroup, I guess we are looking at. Moving on to sort of social outcomes, looking at crimes. So this was a study led by John Bannister's team at Manchester Metropolitan University, and this is one of the earlier ones to get published. And here in these two graphs, the top graph is looking at a time series of all crimes in Scotland. It's on the log rate scale. And on the bottom panel is all alcohol-related crimes in Scotland. And again, this was a Public Health Scotland funded study, and there's a link to the PDF at the bottom there. And again, so this project, this study did not have a control group or a control outcome, but nevertheless, it was suggesting that MUP did not have an impact on levels of crime. One thing to note, and I've worked with crime data a bit myself in Scotland, that you know, there is a kind of quite a big break here, for example, in this alcohol data, and we've observed this as well. And one issue with the police data is, in Scotland anyway, maybe the same in England, is, you know, changes in systems and data capture and over time, which is obviously one of the challenges of doing a natural experiment evaluation. So this was a study looked at a range of, as it says, intended and unintended consequences of the implementation of MUP. This was a study funded by NIHR, and it was led by the Social Public Health Sciences Unit here at Glasgow. And within this study, they used repeated cross-sectional surveys and a difference in difference analysis to assess the impact of MUP on emergency department attendance. And again, just pulling out a sentence there, you can see that MUP, there was no evidence of a beneficial impact within the emergency departments. Again, focusing, I suppose, kind of related to emergency departments, sort of one earlier on in that kind of journey, potentially would be an ambulance attendance. Again, myself and Francesco, we, in prior work which was led by Niamh Fitzgerald at University of Stirling, we developed an algorithm to operate within the capture of data from the kits used by paramedics to identify an ambulance related call out. So we developed an algorithm and we tested its accuracy and so on. And then that algorithm was used within this study. So again, we didn't have a control group, but we had a control outcome. So the red triangles and trend line are for ambulance call outs to under 13-year-olds. And the black circles and the black trend line are the alcohol-related ambulance call-outs. And these are actually daily data, this time series. And again, you can see in the graph, and also when it was borne out in the modeling, that there was, we found no evidence of MUP influencing alcohol-related ambulance call-outs. Another study which was really nice, because this came from a Masters in Public Health student project, and this was using the freely available Stats 19 traffic accident data. So Department of Transport holds this data, which covers all recorded accidents in Britain. Now, there are issues here. So University of Sheffield, John Holmes, Colin Angus, and so on, team did consider that MUP would influence road traffic accident rates. However, when it comes to assessing whether an accident was alcohol related, it's really difficult, because if there is a fatal crash, then to measure someone's blood alcohol concentration, there can obviously be a big gap in time between the accident and then that measurement being taken. May not always be taken, and so on and so forth. So we are clearly using proxies here to be alcohol related. So we used, amongst some other things, road traffic accidents that led to death, and also road traffic accidents that happened at night. And the black line is Scotland, and the red line is England. So again, this study has some limitations, but again, we found no evidence MUP influencing levels of road traffic accident rates. And should note as well, there are other independent studies from us that have looked at this same research question and also reached similar conclusion. So that's a bit of a whistle-stop tour through lots of outcomes, but maybe trying to pull some things together and to have a discussion. So we've observed this positive impact on total and chronic deaths and hospitalization, with evidence of null or perhaps negative impacts on acute harms and acute deaths and hospitalizations. Again, thinking more from the kind of acute side of things, we've seen null effects on crime and emergency room attendance, and missed out there the ambulance call-outs as well. So thinking about if we believe all that, thinking about why that might be, and I've just jotted down a few things, and be welcome to hear others' views. So it could be that acute harms attributable to alcohol mostly come from on-trade alcohol consumption, and MUP did not affect the price of on-trade prices. Perhaps there's some study design and power issues in some of the studies that I've highlighted. So one advantage of the hospital and death study is there's no selection bias there, because it's the data for the whole of Scotland and for the whole of England. However, as you could see there because of the acute being such a smaller percentage of the harms in terms of deaths and hospitalizations, you did see these wider confidence intervals and larger p-values. And some of these other studies, such as I've already sort of described some of the limitations of the road traffic accident study, but the crime and emergency room and so on, again, there might be some selection bias issues in terms of what data is being used. And yeah, be welcome to hear other reasons. So I now wanted to talk about this, going back to this sort of limitation of aggregate level analysis. So I think we can be very confident that MUP in Scotland caused prevention of deaths and hospitalizations wholly attributable to alcohol. But I think identifying the people for which it worked is more difficult. Although we did see this deprivation-based inequalities effect, which is great, which is what we wanted to see. We have some studies are looking within subgroups. So although we think we're confident that deaths and hospitalizations are wholly attributable to alcohol reduced, on the other hand, we have this evidence that those who are drinking harmful levels or have alcohol dependence were not affected by MUP. So this leads me to ask the question, has MUP been mostly successful for those who were severely alcohol dependent? So was there a cohort of individuals who were close to death, essentially, or close to hospitalization, and when the intervention came in, it reduced consumption amongst these people enough to prevent those outcomes. But that links to the second point, which is, MUP is not a magic bullet. So to make this true prevention and not just a death or a hospitalization postponement, there needs to be, the services, the alcohol services in place to address the needs of people who suddenly are still addicted or heavily dependent on alcohol and can no longer afford to buy it in the quantities that they were. And looking ahead to 65 MUP evaluation. So obviously, if we're going to look at a long time series, there are kind of going to now be two intervention points. We're going to have May 2018 and September 2024. So taking kind of a causal inference approach, how are we going to find a counterfactual to these circumstances? Because we know if we're going down to England, as we have been doing in these studies, that we know there was no MUP intervention in May 2018. So does that mean, should we start our analysis from May 2018, for example? Even if we do that, how do we disentangle 65 MUP effects from 50p MUP effects? And how much of the sort of the 50p intervention are there any potential for lag effects coming through? Or it could be maybe even kind of like a cohort effect thing where people, there will maybe a particular cohort affected by the 50p evaluation as they age, they might start coming in and confounding an evaluation of 65p MUP. And the penultimate bullet point there is thinking about methods. And I think this intervention has been incredibly well evaluated by a whole range of studies. And I take my hat off to Public Health Scotland, I think, for doing a fantastic and professional job. However, in terms of the synthesis, I do wonder whether there are other ways of doing that. So maybe we could use all this evidence from these different studies and to sort of maybe try and model in terms of a system, and to try and perhaps model interactions between the intervention itself and some system behaviors. Again, that's an open question. I'm not a systems method expert, but I know it relies a lot on modeling, and then obviously further assumptions are coming in, and there are difficulties there. But I do wonder whether it might give a better insight into what has happened, and how, and again, breaking down this average effect and look at subgroups or individuals of what has happened. And then the final point would be, obviously, I focused on the quantitative evidence, but there are a number of qualitative studies as well. And again, thinking about how to bring these two together, perhaps within a systems modeling approach, I think is interesting and worthy of investigation. So to sum up, as I've just sort of said, I think MUP has been successful in Scotland and it has been extremely well evaluated. And that strength of evidence has led to MUP being continued and at an increased minimum price. I think this demonstrates that natural experiments are indeed a powerful evaluation tool. But as I just touched on, I think synthesizing the evidence is a key challenge. So thanks very much. I'm going to stop there, and hopefully we can have some discussion. I'll throw it back to Frank.
Thank you very much, Jim. That was great. It was really good to see everything together. I personally read some of it, but not all of them. So it's nice to see everything in one go and see what's happening going forward. So there are a couple of questions in the chat. So Jacob has added a couple, and Alexandra just one. So if we just take those from the top, maybe that's easiest. And Jacob asked whether there's any changes in contraband and moonshine detected.
There were, I remember going to a number of evaluation meetings, and there were a number of issues like cross-border purchasing. I think maybe that comes on to Jacob's second point as well. But and also that we heard some anecdotal evidence of people in desperate circumstances and trying to get alcohol from soap and things like this. But I don't know of any evaluation that has looked at particularly in sort of home brewing or what have you. My guess would be that's quite a low proportion of how people are consuming alcohol.
Okay, thank you. I see that Jacob is now visible and has his mic off, so he can do his next two.
Okay. Yeah. Thanks for that. One just on the sort of mystery of why chronic goes down and acute goes up, and I just wonder, could there be sort of behavioral changes that for some reason, I can't say it's logical, but that of course you can go and drink and a little bit all the time, or you could have you can sort of have more binge drinking events, and it's, I guess it's an issue for youth drinking. They would say the binge events can be actually be more harmful than if you sort of spread it out more. And there's something that will be picked up in a lot of surveys around this kind of more extreme drinking events, and I wonder whether it's something that could be behind some of these slightly strange changes.
Yeah, no, it's a good question. I think so. I think in that John Holmes study I referenced, I think that they did look in their surveys at sort of changes in patterns of alcohol consumption. And I don't think they found much evidence for it. But again, I think your point relates to these sort of unanswered questions that that this natural experiment approach can give you if you're relying on sort of interrupted time series. Is very insightful, I think, and you can look within subgroups, but that kind of more nuanced thing in terms of working out, well, who exactly did this intervention work for and who didn't, and what are those unintended consequences, I think it's tricky. And yeah, you'll note in that theory of change that it was written safer consumption of alcohol or something, safer pattern, and I'm not sure we have really got the evidence for that yet.
Thanks.
Just to flag, I'm taking a bit at the top because Peter just commented that there were no reports from hospitals of homemade alcohol or non-beverage alcohol after the introduction. So quite possibly that's not too much of an issue then. Jacob's third question is quite interesting. Is there any correlation with the driving distance to the English border?
Yeah, so good question. So I wasn't personally involved, but I do definitely remember that there was a concern. There was a concern about people driving over the border. So that's what's behind your question, isn't it? And like internet purchasing and somehow getting away from the fact that you're living in Scotland. So I would point you towards the Public Health Scotland's website, because there probably are reports on that. But my recollection, it was maybe a bit of a red herring. There didn't really seem to be much of that going on.
Okay.
Thank you. Before going to the next one, I had a quick question that I wanted to check. So you report that there's no harmful levels, no effects on those drinking at harmful levels or with alcohol dependency. So does that mean that those people have spent more on the same amount of alcohol, and that comes at the expense of something else, say food, for example, or such things? Is there any evidence on that?
So again, I think there are some papers that are looking at whether people are spending less on food. And again, I think the evidence might be a bit unclear and mixed, but I don't think there's great evidence for that happening. But yeah, I think my point for those bringing in those studies, I think those two particular studies I mentioned, they are difficult because they're based on, well, the study I was involved in is based on prescribing, and we know that is for severe people with severe alcohol dependence, and we also know that there's under prescribing goes on. People should be on drugs to treat their alcohol dependency aren't, and the study from John Holmes and his team, again, that was based on sort of an internet survey, and so it doesn't have sort of a national coverage picture. But I think it is useful in terms of speaking to that point, in that we're not really sure from the evidence about for those people with alcohol dependence, can we pinpoint, yes, MUP is going to work for that person, no, it's not going to work for this person, and for these reasons.
That makes sense. Thank you. The next question is from Alexandra. It's quite a complicated one, and I think it's more of a suggestion for analysis.
Well, let me read it. Yeah, that's a good point. And as I said at the beginning, Alexandra, if you account for inflation, I can't remember what 65p now is. What 50p would be now in 2024 and so on. But there was an economic evaluation of MUP. A lot of it was focused on, did it damage the alcohol industry in Scotland, and it didn't. But I think your question is very pertinent, because I think when we're trying to, as you say, disentangle if there's a maintained effect, or it seems to be some apparent increase in effect, working out exactly, was that due to increasing the dose, if you like, of MUP, or was it just that MUP was maintained? I think that would need to be thought through and teased out. Thank you.
Thank you. The next question is from Lynn. If you've evaluated the density of off-license shops, or possibly not you, but somebody.
So yes, there definitely have been studies. I can't remember one off the top of my head, or which groups. It might be Sheffield again, actually, but and yeah, that's there are studies. I mean, obviously, I think it's a related point, but obviously, even if there was more dense shops, I suppose it could be a confounder, I guess, if there was a change in density of off licenses in Scotland compared to England, potentially that could be a time confounding variable, I guess, for when we evaluate MUP. But of course, in Scotland, no matter how dense or whatever they are, they wouldn't be allowed to sell less under the minimum unit price. And as I said right at the start, that compliance to that was really good. So there were people going undercover, I believe, into off licenses and checking the prices of the alcohol was being sold out, and compliance was really good.
Right, thanks. The next one is quite a nice question from Andrew, whether consumption dropped for all types of alcohol or whether it didn't affect middle class wine drinkers is the example, for example. Is that something that's been looked at?
So we, as I said, in the deaths and hospitalization study, we saw a very large socioeconomic deprivation gradient, and it kind of made sense because it was the alcohol that MUP hit hardest, if you like, was the very high alcohol content ciders and the very cheap vodka and white spirit that we are aware is that there is that is socioeconomically patterned in terms of that kind of consumption. So I think that is giving a hint that yes, how MUP impacted different people in terms of how they consumed alcohol, absolutely right, and that indeed was in some way deliberate in that, and so that the MUP had a chance of narrowing socioeconomic inequalities.
Yep, thank you. In the interest of time, we've got one last question from Peter. I can see Peter in the screen, so if you want to ask the question yourself, Peter.
Okay, thanks, Frank. And yeah, great presentation. Yeah, so, might the fact that people who would otherwise have died have survived to be entered into studies post-MUP, influence this finding that consumption hadn't changed, much in that group. And my second point, just on prescribing access, is that we've had a big fall in specialist treatment access in Scotland for a number of reasons, and those would be the services that would normally be recommending the prescribing to GPs. So I think that makes the prescribing even more difficult to interpret. But yeah, the survivorship bias is one that I'm interested in. Is there a way to tease that out?
Thanks, Peter. Yeah, good question. I think the survivorship bias, I haven't given it a lot of thought, but I guess you're right in that if there has been, we're kind of reducing those people from the denominator, and that thinking through how that would work. I mean, there are methodological approaches to try and account for survivorship bias in modeling. So I think that's a really good point and something we go away and think about. And the prescribing, I absolutely take your point. And I guess in terms of the natural experiment, perhaps but I guess prescribing access fell in England as well as Scotland, and whether you did have, we didn't, but if you did have access to prescribing in England, whether that could still get you at a counterfactual. But yeah, I agree that study, there are some limitations to it in terms of we know that underprescribing goes on.
Great. Thank you very much, Jim. I think we'll close this. So once again, on behalf of me and I think everybody else who listened, thanks for presenting. I thought it was great, and thanks for answering all the very good questions. With that, I'll close this bit just to say the network doesn't have a next seminar planned. So if you have something you'd like to present, and just get in touch and let me know, and we can easily set it up. So thank you very much. And for those that are members of the School for Public Health Research, we may all see each other next week at the annual conference. So thank you very much.
Thanks, everybody. Thanks for coming. Bye.